Lesson 5, breathing, ventilation, and oxygenation. Structurally, we have the ribs. There are 12 pairs of ribs, 10 of which are attached to the sternum and the spine, and 2 pairs which are only attached to the vertebrae in the back. There is also underneath each rib an intercostal nerve, artery, and vein that runs along the inferior border and hangs down slightly from each of these ribs. The lungs on either side of the heart. Then we have the mediastinum, in which the great vessels and the trachea and esophagus can be found. As you can see from the picture, the trachea comes down, intermingles between those great vessels, branches off into the left and right main stem to provide oxygen to the lung, and you see the vessels coming in and out of the heart all through that area as well. The mediastinum also containing the heart and the major arteries, the aorta, which branches off into the carotid arteries and the brachial arteries. You also have the pulmonary arteries bringing oxygen from the heart to the lungs. And don't forget, you also have the vena cava, which brings the blood from the body back into the heart through the superior and inferior vena cava. And you have the pulmonary veins as well. So oxygen is transported across the alveolar capillary membrane. We talked about this in the earlier lectures. It then attaches to the hemoglobin. So we need to have a significant amount of red blood, and we need to have red blood that has hemoglobin. So this may be a problem in some patients, especially your anemic patients, elderly patients, etc. As the oxygen is moving in to the bloodstream or across the wall into the circulatory system, carbon dioxide is leaving the circulatory system and coming out into the alveoli to be exhaled. So breathing is the mechanical act of moving air into and out of the lungs. There is a section of your brain in the brainstem that controls this, and it's generally controlled by chemical reactions or chemoreceptors that are located in your aorta and carotid arteries, but also by measuring cerebrospinal fluid pH. When the body detects that your pH is decreasing because you're becoming acidic, it will stimulate you to breathe, thus blowing off the carbon dioxide and bringing in oxygen. So in normal ventilating patients, their stimulus to drive is actually caused by a rising PaCO2 level. As carbon dioxide rises, it stimulates us to breathe. Compare this to patients, though, elderly patients who have COPD. In those patients, hypoxic drive may be what drives them to breathe. In other words, because of the smoking and the years of exposure to chemicals such as carbon monoxide, carbon dioxide, etc., the drive to breathe is stimulated by a low oxygen level. But in most patients, it's a large or high CO2 level. You don't notice patients when they're breathing normally. You notice that they're breathing, but you don't pay attention to it. It's the patients who have something abnormal that catches your attention. If you walk in and you can hear the patient breathing as you enter the room or as you approach the vehicle, if you see that they are positioned in a way to make them breathe, or if they're actively labored, or if they can't even speak a full sentence without stopping to take a breath, these are patients who have problems with their breathing. You want to look at the chest rise, look at their effort, look for retractions. You want to listen to the lungs, listen anteriorly and posteriorly if possible. And you also want to feel the chest, palpate for any fractures. Is there anything wrong? Is there any areas where there's pain when you push or palpate? So when we look, let's observe their positioning. Are they sitting up? Are they tripoding? Do they breathe better when they're sitting up or leaning forward? Do they breathe worse when they're laying down? Are they using any accessory muscles? Infants tend to use their abdomens more to breathe. Older children and adults will use more of the chest muscles. Do you see any retractions? Again, infants may have sternal retractions. Older patients may have intercostal retractions or subclavicular retractions. They may also use neck muscles and the muscles in the shoulders more to breathe. Nasal flaring, more common in children. They don't have as much cartilage in the nose. It tends to be a little bit more flexible and move. So look for nasal flaring as well. Also listen for sounds like grunting and those earlier sounds we talked about in the airway section, stridor, grunting, etc. Those all tell you that, yes, there's an airway issue but airway leads to breathing, and they're going to breathe harder to try to compensate for that. We're also going to look to see if we see anything on the chest, such as contusions, hematomas, any lacerations, those sucking chest wounds where you may actually see sucked in or you may see bubbling of blood coming out. Is there paradoxical chest wall movement indicative of a flail chest? Right? Is there unequal chest rise, which may be indication of a pneumo or a tension pneumothorax? And we're going to listen as well, and we should listen, again, both sides, and we should listen anterior and posterior if at all possible. Is it decreased on one side? Is it diminished? Is it decreased on both sides? Do you hear fluid in there? Do you hear any abnormal sounds such as wheezing or rhonchi? Remember, wheezing, a sign of constriction. We'll see that more often in patients who have asthma, emphysema, maybe with anaphylaxis, but can also be found in patients who have damage to those bronchioles or to those small airways, maybe from chemical inhalation, things like that. Rales, generally indicative of fluid, especially in the small airways like the bronchioles and the alveoli. This could again be from a chemical exposure. Could also be from fluid in there. If there's anything impeding the heart, the left ventricle output, remember that's going to back up. So patients with tamponade, you might want to be looking for this as well. Fluid overload in patients may also cause rales. Rhonchi, generally fluid in the larger airways, more in the bronchuses, and this could be, again, fluid, could be mucus, could be blood, could be vomitus. So we want to listen for those as well. Really not much we could do about that, but definitely note it. And any crepitus, subcutaneous emphysema, any crepitus in the bones, the sternum, the ribs, anything like that, that would be something that would tell us that there's fractures in there. So all things to look and to listen for. The crepitus of broken bones, subcutaneous emphysema. Don't always assume that it's here in the upper chest or right here in the neck. Air, like water, will go through the path of least resistance, which means sometimes it can go underneath into the armpit areas. Sometimes it can go up high. Sometimes it can go up here above the shoulders. So look all around for it, feel for it as well. If you see any abnormal movement of the chest wall, definitely assume some sort of breathing difficulty. But again, reassess that and constantly reassess it to make sure it isn't a tension that's getting worse, or a flail chest or something of that nature. So for our pneumothoraxes, we have a couple different types. We have the simple pneumothorax, the tension pneumothorax, and then we have an open pneumothorax, which most of us probably know as a sucking chest wound. You could also have a hemothorax if there's blood in the lung. And for the rib fractures, you could have just a simple rib fracture, or also the flail chest when you get more than a couple of ribs broken in a couple of places. So this pneumothorax, 20% of the chest injuries are going to have it. Simple pneumo, tension, or the open. Simple pneumo, area where the visceral and parietal pleura have pulled apart or separated. If there is any sort of hole or ability of air to leak out of the lung into that pleural space, it can become a tension pneumo. So don't just assume that it's a simple pneumo now, therefore it will stay that way. It can certainly get worse over time. If it is a tension pneumothorax, that can be life-threatening and will need to be decompressed as early as possible to prevent it from getting worse and causing cardiovascular problems down the road. There may also be a hemothorax in there as well, so there may be blood in that space. Right? It could be any one of those. And really for us, it's going to be on presentation and symptoms for us to try to identify. So the simple can be from blunt or penetrating, as can the tension. The decreased breath sounds can be decreased or absent in both as well. You will notice in the simple pneumo that there may be mild or moderate ventilatory distress, but a simple by itself that stays that way won't continue to get worse. A tension is going to have marked ventilatory distress and get worse and worse and worse. All right? It will not get better or stop or plateau. The simples will stop or plateau more likely, but your tensions are continuing to get worse. And as those tensions get worse, you're going to see more hemodynamic problems as that lung starts to shrink and we get a shift in that mediastinum. Pressure on the heart, pressure on those great vessels, especially the vena cava, are going to decrease blood flow, and it's going to cause a hemodynamic drop in cardiac output, and you're going to see mentation drop, level of consciousness, that's all going to go down. Blood pressure is going to decrease dramatically, and that sure sign that you've got a tension pneumo. The simple, as long as it stays that way, will be okay. Rarely will need decompression, but it might. But it may turn into a tension, so obviously still maintain, assess, and reassess of that. So the open pneumo, which most of us know as a sucking chest wound, is probably how you learned it in school. This is a opening that goes through the skin, through the muscle, through the visceral and parietal pleura of the lung. So what happens is you have a complete air hole, if you will, from the outside all the way in. So as your patient takes a breath, that negative pressure inside may actually draw air in through that hole, hence the sucking sound. And when they exhale, that positive pressure inside pushing out may push some air and blood out, giving you that bubbling looking chest wound. The respiratory distress may be anywhere from mild to severe, and again, there may be a hemothorax with it as well. Most of you probably learned to put an occlusive dressing on 3 sides with one side open, and honestly, 3 sides, 4 sides, neither side has been proven to be more beneficial than the other, but just make sure you reassess in case it becomes a tension pneumo and needs to be decompressed or the air needs to be alleviated from that wound. For a hemothorax, this can come from blunt or penetrating trauma, but you have blood in the pleural cavity. So you have blood filling in the space instead of air. Sometimes you can have both. You can have what's called a hemopneumothorax, where you actually have blood and air in the same spot. All right. Again, for us, it's hard to determine which one it is. If they have hemodynamic compromise and we believe that it is a tension pneumo, then you are going to decompress. All right. They are going to have a drop in blood pressure and a drop in their cardiac output, because if it's bleeding, just like if they were bleeding on the outside, you can expect some hypovolemia. Right? If it is a pneumo and we have the tracheal shift and the jugular vein distension and we have all those other signs, then it's more likely a tension pneumothorax. For simple rib fractures, very common thoracic injury, but it's usually the ribs down here, not the upper couple of ribs, 2 or 3 ribs. It's usually these right in here that get broken, all right, and rarely the floating ribs. Can also cause a hemothorax because that broken rib can cause injury and cause bleeding into that space. Common cause of chest pain and shortness of breath from chest trauma. And remember, those ribs also cover over the liver and the spleen and in the back in the kidneys. So a fracture of those can cause injuries to those solid organs, which are prone to bleeding as well. Your flail chest is when you have at least 2 or more ribs that are together, broken in at least 2 places or more. All right, this will give you a free-floating section of rib. And the problem is, when you breathe in and out with your negative and positive pressures in and out, that will actually cause the broken section of rib to move in the opposite direction of what it should while you're breathing. Okay, so this will cause that paradoxical chest wall movement that we typically look for. Some patients, the muscles will tighten up and have very little movement, but in some patients it may be more pronounced. You may also have a pneumo or hemo with this, and you may also have pulmonary contusion. It took a tremendous amount of force to break all of these ribs in that spot. You may damage the lung underneath it with a contusion, or you may have a hole or bleeding into that lung as well, causing the pneumo or hemo. So your treatment for these chest injuries, obviously oxygenate to these patients, because injuries to these chests are going to limit or cause problems with ventilating properly, so therefore we want to make sure that we oxygenate them. So supplemental oxygen, which is going to be non-rebreather. Assistive ventilations if we have to. Some of those patients may not be breathing very well or adequately enough on their own. Patients with flail chest may not be able to breathe even though they may want to, and they may not be able to breathe well as well. So for those patients, positive pressure ventilation if we need to, and also consider intubation. If we have any open wounds, let's seal those wounds with an occlusive dressing. And for the patient with the pneumothorax, the tension pneumothorax specifically, we need to recognize that and decompress that. Now, if you have a suspected tension pneumo in the beginning, but your patient is alert and talking to you but has trouble breathing, don't delay on-scene time to further evaluate and determine whether it's tension or not. Remember, if your patient's awake, good mental status, they're still breathing, yes, they may be labored, yes, they may have poor sats, give them some oxygen, let's get them in the truck, get the equipment set up, and decompress on the way to the hospital. Don't delay your on-scene time unless your patient is absolutely 100% unresponsive, and they may still be breathing, but not adequately, that's a patient you may decompress right now. But most of these patients, probably by the time you get there, assess it and realize that it's going to be a little bit down the road, do it en route to the hospital. Continuously reassess their breathing though. Don't assume that a simple pneumo won't become a tension, or if they're simple, they're good. Anything can change in these patients at any given time. So constantly reassess your breathing using not only visual clues, but auditory, listen, and use your devices as well. Do not assume that a good SAT or a CO2 is okay. If your patient is breathing harder and harder and harder to maintain those numbers, eventually they're going to get tired and fatigued. Use all of your senses to determine whether your patient is breathing adequately or not. As far as supplemental oxygen goes, non-rebreather mask, bag valve mask, ventilator. Notice we didn't say nasal cannula. For these patients, oxygenation is key. Remember, one of the triangle of death sides was acidosis, and that most often comes from hypoxia and switching to anaerobic metabolism. So make sure your patients are oxygenated. Never withhold it, especially from those in respiratory distress. And one of the things that constantly people think is that COPD patients should not get high flow O2, and nothing could be further from the truth. Those patients, if they need it, they get it. All right, monitor their SAT. Obviously, we'd like a target SAT greater than 95%. That may not be possible in all patients, especially those COPD patients, but if you can get those patients into the 91, 92% range for them, probably fantastic. But we'd like, if we could, to get the patient SAT up around 95% or higher. Remember that oxygen is needed to ward off that anaerobic metabolism. We want to keep them using oxygen in the aerobic metabolism or Krebs cycle. If we need to ventilate, right, ventilatory rate greater than 30 or less than 10, then we're probably going to consider assisting ventilations. But again, use your senses and common sense as well. A patient who just wrecked their brand new car may have a respiratory rate of 34, 35 because they're anxious and upset. That doesn't mean that they need to be ventilated, okay? Patients less than 10, for the most part, are not properly oxygenating, and those are going to be ventilated. All right? But your patient rate greater than 30, again, look at your patient. Why are they breathing that fast? If it's because of trauma, they're hypotensive, tachycardic, they have a chest injury, etc., that patient's probably going to need to be ventilated. If they have poor chest rise or using accessory muscles, these patients are already in a bad spot. They're already to a point where they're starting to use accessory muscles to breathe. They're not getting good ventilation. Those patients you need to start ventilating immediately. Decreased SAT, increased CO2, these are all signs. As ventilation decreases or the effectiveness decreases, we're going to get less oxygen in and more CO2. And remember, carbon dioxide is the byproduct from metabolism. And if we have a lot more CO2 coming out, we are producing a lot more, which means we may be switching to anaerobic metabolism. Again, one of the sides of the triangle of death. And advanced airway management, do we need it? Do we need to go further? Is our non-rebreather working? Yes, no, no. Let's go to our next device. Let's start bagging them and consider intubation. Not very good with intubation, haven't done it in a while, we're not good at it. Let's put it in a King or an LMA or some other device. All right, but increase or go to your next step if what you're doing is not working. So there you see them bagging with the patient on the left. That's a nice two-person bag valve mask technique. One person holding the mask to get a good seal, the other person squeezing the bag. All right? And again, make sure you use an oral pharyngeal airway or nasal pharyngeal airway to assist your ventilations. Some of the other devices like a ventilator, things like that, those can be used as well. If you need personnel, if you don't have enough people to do a two-person, one person can hold the mask, the ventilator can do the squeezing for you. Just know that in patients who need higher pressures, some ventilators, especially portable ventilators used in EMS, if there's resistance or back pressure, they may not be able to overcome that pressure and you may have to do it by hand. As far as the rates and volumes go, for adults, 10 to 12 breaths per minute. You see there about 500 to 800 mLs. Again, just enough to make the chest rise. The average person breathes approximately 500 to 650 or so, and maybe a little bit more in some of your larger patients. But we don't need to use that entire bag valve mask. Those bags generally have anywhere up to 1,200 cc's of air. You don't have to squeeze the whole bag, just enough to make the chest rise. For children, you see the rates there of 16 to 20 breaths per minute, and again, about 100 to 500, or again, until you get good chest rise. And then for infants, 25 breaths per minute, obviously a much higher rate because of their higher metabolism and oxygen demand. But you see there are only 6 to 8 mLs per kilo. And again, just you want to make sure you get the chest rise. Again, be very careful in these infants and children about overventilating, especially for infants. Overventilation, if it gets into the stomach, it will cause gastric inflation, and that will impede good ventilation. All right, for the capnometry and capnography, remember we said capnometry is the number, capnography is the waveform picture. So we can use it on spontaneously breathing patients. Generally, we have a nasal cannula type device that'll measure. We can use it when we bag or tube patients, or if we use the supraglottic airway devices as well. A normal capnography reading or capnometry reading is between 35 and 45 millimeters of mercury. In hypotensive patients, it may give off false readings, but you could still use it to look at what's happening. Is it decreasing? Is it increasing? Is it changing? It may not be as accurate in hypotension, but you can still follow it to see if there's any trends that develop out of it. So 35 to 45, that's what most normal people are breathing at, and that's where we would like to keep our end-tidal CO2 reading if we're using it. It's also a good device to use for monitoring your tube to make sure that it's still in the right place. So needle decompression for patients who have a tension pneumothorax. Preferably the second intercostal space, mid-clavicular is where we're going to go. So remember, you want to go over the rib, so over the third rib into that second space. The reason is, remember, those nerves and blood vessels are going to hang down from the second rib. So find where the third rib is. Do not aim right directly for the third rib and try to bend your needle up and over it. All right, you just want to aim over that rib into that intercostal space and alleviate that tension pneumo. If you cannot use those sites for whatever reason, the fifth intercostal space can be used as well, mid-axillary. Just be careful, find your landmark up top and find the fifth intercostal space and move over. Do not start counting from here, fifth intercostal space. You can end up too low and end up in the liver or the spleen. So in summary, respiratory patients, we need to maintain the airway. So it goes back to that beginning A, maintain a patent airway so they can get air in and out. Supplemental oxygen if they're not getting enough oxygen. Assist them if they need to. Bag them, intubate them, provide the ventilation and oxygenation that they need. Definitely recognize and decompress those tension pneumothoraxes because they will cause hemodynamic drop and could kill your patient. All right, that concludes this section. Please review and complete the questions for this section. Thank you.